is what your kitchen looks like, you may not be good with change. And by the end of this video, I'm going to explain to you why carpets in your kitchen are a bad idea and why your patient may not need that beta blocker. This is On Second Thought. Giving patients a beta blocker after a myocardial infarction is standard of care. It's in the guidelines. It's one of the performance measures used by the ACC and the AHA. If you aren't putting your post-ACS patients on a beta blocker, the ACC and the AHA both think you suck. They are very disappointed in you, just like your mother was when you told her you didn't want to become a surgeon because you don't like waking up early and your hands shake when you get nervous, and it's not your fault and there's nothing you can do about it, so just leave me alone. But the data on beta blockers are decades old. In the time before stents, statins, ACE inhibitors, and dual antiplatelet therapy, when patients either died or got better on their own, beta blockers showed major benefits. Studies like the Norwegian Multicenter Study Group, the BHAT trial, and the ISIS-1 trial proved the benefits of beta blockade. But these studies date back to the 1980s, when you could call a study ISIS without controversy. It was a simpler time, where all you had to worry about was the Cold War, apartheid, and the global AIDS pandemic. It was a time when doctors smoked in their office and patients had bigger infarcts that caused large scars and systolic dysfunction. But that world is no longer our world, except for the war and the global pandemic and the out-of-control gas prices. The reality is that before troponins, we probably missed most small heart attacks. Now, most infarcts are small and most patients walk away from their heart attacks with essentially normal hearts. So do beta blockers still matter? If you're a fan of Cochran reviews, the answer is yes. In 2021, Cochran published a review of beta blockers in patients without heart failure after myocardial infarction. The authors of that analysis concluded, after the usual caveats about heterogeneity and potential bias and the whims of a random universe, that yes, beta blockers do reduce mortality. The risk ratio for max all-cause mortality was 0.81. What does that mean practically? The absolute risk was reduced from 10.9% to 8.7%, a 2.2% absolute decrease and about a 20% relative drop. A little math gives us a third number, 46. That's the number needed to treat. If you think about how many patients you admit during a typical week of CCU with an MI, a number needed to treat of 46 is a pretty good trade-off for a fairly inexpensive medication with fairly minimal side effects. Of course, these are the same people who claim that masks don't stop the spread of COVID. And sure, were they the only people who thought that hand washing was the best way to stop a respiratory virus? No, we all believed that fantasy for far longer than we should have. And not everybody can bat 1,000, if by batting 1,000 you mean reflecting on how your words will impact on a broader population primed to believe misinformation because of the increasingly toxic social media environment and worsening politicization and radicalization of our politics. By the way, if any of you want to come to Canada, you can stay with me. Things are incrementally better here, and in this day and age, incrementally better is the best we can hope for. But here's the wrinkle with the Cochran beta blocker review. A lot of the studies took place before early revascularization became the norm, and before our current armamentarium of drugs became standard of care. Back in the day, bed rest and the power of positive thinking were the mainstays of cardiac treatment. Also, a lot of these studies mix together STEMI and non-STEMI patients. So you're obviously going to see more benefits in STEMI patients who are at higher risk. And some of them used IV beta blockers right away, while some were looking only at oral beta blockers started days after the infarct. And we don't use IV beta blockers that much anymore because of the risk of shock. Also, some studies had short-term follow-up where the benefits were less pronounced, and some studies used doses and types of beta blockers rarely used today. And some of the studies had a mix of coronary and heart failure patients, which muddies the water because the heart failure patients would clearly benefit from being on a beta blocker. So basically, the data is not definitive because it's old, and it doesn't reflect our current standard of care, and it contains a heterogeneous mix of patients that aren't really relevant to the question that we're asking. And the question we're asking is, should you put all your post-MI patients on a beta blocker routinely, even if they don't have heart failure? The REDUCE-AMI trial is the first of a few trials testing, or to be more accurate, retesting, whether beta blockers are useful after a myocardial infarction. Beta-MI, Reboot, DanBlock, you'll be hearing these names in the next few years, either because the studies get published or because they're Twitter handles of people harassing you online. Either or, by the way, I'll be cold in my grave before I call it X. But for now, reduced AMI is the first to cross the finish line, and at least in cardiology, finishing first is a good thing. This study enrolled patients with ACS, both STEMI and non-STEMI, with a post-MI EF greater than or equal to 50%. And the result was nothing. The risk ratio for all-cause mortality was 0.94 and was not statistically significant. In absolute terms, that's a reduction from 4.1% to 3.9%, or a 0.2 percentage point decrease, which translates into a number needed to treat of 500, 10 times higher than what the Cochran review found. And that's if you assume that there is in fact a small benefit amidst all the statistical noise, which there probably isn't. Now, studies like this can never rule out small effects, either positive or negative. So maybe there is a small benefit from using beta blockers. But if it's there, it's really small. So do beta blockers work? Well, yes, obviously, for heart failure and atrial fibrillation, which, let's face it, are not exactly rare and often coexist in patients with heart disease. They probably aren't that great as blood pressure pills, but that's a story for another day and another video. So yeah, beta blockers are useful pills, and they are standard of care, just maybe not for post-MI patients with normal ejection fractions, because they probably don't really need them. They worked in the pre-stent, pre-aspirin, pre-anything era. But that's not our world anymore. Things change. Because it's not the 1980s. That's why I don't have a mullet, and that's why you need to update your kitchen. For Medscape, I'm Christopher Labos.